came to decisions concerning allocation of resources to people with severe mental illness. One is the insistence on a measurable improvement in health. The other is on the fact that the weights are meant to reflect the value that the community would give to being in a health state, and that most measures used in practice involve at one stage community surveys of how people rate different health states. So first, as I said, qualities seek to measure changes in health. I'm just back from a year on sabbatical in the UK, and one of the features of the landscape over there, which I found interesting, is the sharp distinction that the English make between healthcare and social care. Some of the colleagues I spent time with, Anne Metlin, Julian Porter, and others, who are at this point interested primarily in care for the elderly, are trying to develop a social care counterpart to the quality. Right, and as they point out in the quality framework, how can we justify care that is not curative, but that is simply care? The difficulty is compounded when we consider care for people with severe mental illness. The care they need straddles both health and social care. Assertive community treatment teams, for example, are multidisciplinary teams that go out into the community where the people with severe mental illness are, and provide integrated treatment, rehabilitation, and support. What this implies is that colleagues are likely to understate the benefits of mental health care to people with severe mental illness, to the extent that the social care component is worth something. The second aspect of the quality procedure that I want to remark on is its reliance on community sample ratings to rate health states. While this seems natural and objective on one level, at a deeper level, it raises some fundamental questions. One somewhat technical question is the extent to which general members of the community can really appreciate what the health state is like. In a remarkable address at the closing plenary of the 2005 International Health Economics Association meetings in Barcelona, the Nobel Prize winning psychologist Daniel Kahneman, as a psychologist who won the Nobel Prize, is the only one so far, observed that people adjust to most health states. We adjust to being confined to a wheelchair, he said, because we can only pay attention to one thing at a time, and after a while we get used to being in a wheelchair and we start paying attention to other things. There are states, however, that we never adjust to because they constantly call attention to themselves. In this regard, he mentioned in particular severe chronic pain and severe depression. His argument was, in effect, that when healthy people evaluate health states, they tend to underestimate the quality of life of people in health states such as being paraplegic, and overestimate the quality of life of people who are in severe chronic pain or severely depressed. It seems to me he's probably right about this, and that what he said about depression is true to some degree of mental illness in general. So what we're talking about here is a cognitive problem in estimating the quality of the health state. But there is also, it seems to me, a likely ethical problem with community ratings. If we stop to think for a moment, we realize that the values of the community are not always and necessarily what most of us would consider ethical values. Nazi Germany provides an obvious case in point, but there are many others, including in our world today. To take an extreme but not entirely unrealistic example, how would we feel about a society whose healthcare economists concluded, on the basis of community ratings, that no or very few resources should be allocated to the needs of permanently disabled people? I don't think many of us would say, well, these health economists were appropriately reflecting their society's values. There's nothing wrong with that.